Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Learnit, serving as the allocated session assistant to ensure a seamless experience. Clarinet is India's most trusted and widely used digital platform offering a multitude of entry services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this event hosted by Indian College of Anesthesiologists. The focus of today's session is beyond landmarks transforming neuraxial anesthesia. So let's begin today's session, for which I would like to invite Dr. Manjula ma'am to take over. Over to you, ma'am.
Thank you very much, Swastika, for the kind introduction of mine and Clarinet and ICA. On behalf of Indian College of Anesthesiologists, I welcome all the dignitaries, those are there on the dais, and all the audience, those are going to listen to us today. Without any further delay, I would like to invite my co-moderator, Dr. Shilpa Tivaskar. She doesn't need any introduction now on this platform, as she has conducted many webinars with me on this platform. So, Shilpa, over to you. She's going to introduce today's speaker for the day.
Yeah. Thank you, Manjula Madam. Manjula Madam is doing this webinars with lot of compassion and determination. And thank you for taking me as co-moderator. And thank you, ICA. Our speaker today is a dynamic person, and we have told him to share the screen, please.
Yes, ma'am. Sharing.
Yeah, thank you, Dr. Viral. So Dr. Viral is a consultant anesthesiologist at PD Hinduja Hospital and Medical Research Center, Khar, Mumbai. Sir's areas of interest are regional anesthesia, POCUS, obstetric anesthesia, difficult airway management, and anesthesia for bariatric surgeries. Sir's publications are, he's an educational board member. He's an educational board member of NISORA. Sir has received ISA National Young Talent Award at ISACON Raipur 2025. Congratulations, sir. And sir is an executive committee member of ISA Mumbai Metro Branch. Sir is an editorial board member of Journal of Trauma, Anesthesia and Resuscitation and Critical Care. Sir is a reviewer of NISORA's Anesthesiology Manual, Best Practices and Case Management. That's a great achievement, sir. Sir is a reviewer of NISORA's Anesthesia Updates 2025, and Sir is faculty for various cities, state, and national CMEs, workshops, and conferences. Sir has 4 publications and 1 book chapter. We welcome you, Dr. Viral Parikh.
Thank you, Shilpa Madam, for such a kind introduction. So at the outset, I would like to thank the Indian College of Anesthesiologists, Dr. Manjula Sarkar Madam, Dr. Jayashree Madam, Dr. Shilpa Madam, Dr. Bimla Madam, for inviting me and giving me this opportunity. My talk for today is on Beyond Landmarks Transforming Neuraxial Anesthesia with Ultrasound, and it will be a case-based applications. Can I start, ma'am?
Yes, please. Yes.
Sure.
Yeah.
So, to begin with, I have no conflict of interest, and appropriate consent of the patient as well as the volunteers have been taken for this talk. So before we begin talk about the ultrasound guided spinal and epidural, I would like to mention about the history. So how the spinal and epidural evolves. So long back in 1885, Professor James Leonard Corning described epidural anesthesia. In 1898, Professor August Bayer performed intrathecal anesthesia. And till now, we have been performing both spinal and epidural by identification of interspinal space by palpation and tactile localization of the bony landmark. So what we do is we identify the Taffier's line, which is the intercrystal line. It's a virtual line connecting the highest points of the iliac crest, and generally it intersects spine at L4 spinous process or L4, L5 intervertebral space. But how accurate it is? Are we correct most of the times? Let us see. So there have been multiple studies. So this was in 2019 about accuracy of Taffier's line by palpation methods in obese, pregnant, and control groups. So what they concluded that was the palpation method was found to be inaccurate surrogate for L4, L5 vertebral interspace for obesity with or without pregnancy. Coming to this another article in 2014 about vertebral level of Taffier's line measured by ultrasound in parturients in lateral decubitus position. They also mentioned that the vertebral levels were more capillary in the parturient women compared to the non-parturient women. And the study mentioned that in most of the patients, the Tuffier's line, which should correspond to L4, L5 interspace, it was more higher, like in at the level of L3 or L3, L4 vertebral levels. And in few patients, it was also up to L2, L3 levels. Similarly, this was another study about ultrasound measurement of vertebral level of Tuffier's line in elderly women. And they also mentioned that the vertebral level in with ultrasound measurement in the left lateral decubitus flex position was more capillary in elderly women than those in the control group. So traditionally, if we palpate the Tuffier's line and put a needle, the needle could be inserted at the higher level than expected. So these were the findings of their study also. Out of 50 patients in each group, so in elderly patients, almost more than 35 or 36 patients had a Tuffier's line which corresponded to a higher vertebral space. So this was the red zone which we could encounter if we are not at a specific or a particular level. So what is the clinical significance? All of us know that the spinal cord usually ends at the level of L1 vertebrae. And this was a case report in which they studied 7 cases, and it was on the damage to conus medullaris following spinal anesthesia. So it was a cadaveric study. So what they identified that in few patients, the risk of spinal cord injury was higher since the cadaveric study shows that the spinal cord ended at the L2 upper or as high as L2 lower levels. And most of the patients, it usually ended at L1 level, but in around 20 to 30% of the patients, even the MRI studies showed the similar findings. So if you put a needle at that level, and if we are at a higher level compared to the L3, L4 or L4, L5 interspace, there is a possible risk of spinal cord injury. And what are the most common group of patients who might have that risk? It is mainly in morbid obese patients, in pregnant patients, elderly patients, or in patients with spinal anatomical deformities or post-spine surgery. So what are the advantages of ultrasound? It helps, it is definitely a non-invasive procedure. There is no radiation exposure, so can be done in pregnant patients. It's a bedside produce procedure. It can be reproduced and repeated multiple times, and it increases the success rates. So with the help of ultrasound, it helps us to identify the midline. It helps to identify the intervertebral level. It helps to insert needle, and also it helps us to determine the trajectory, at what angle we should introduce our needle. It also helps us to identify the depth at which we can get our spinal or epidural, or can be a guide for certain anatomical variations like deficit in the ligamentum flavum or certain spinal deformities like kyphosis, scoliosis, or in patients who are post-spine surgical patients. So as I mentioned about the incidence of the ligamentum flavum midline gaps. So this was again a cadaveric study. On the left side of the picture, you can see that in the center there is a So there is a gap in the midline compared to a normal patient in which there is a no gap in the ligamentum flavum. And this study mentioned that this incidence of midline gap was higher at L1, L2 level compared to the lower levels. And they mentioned that using the midline approach, one cannot therefore rely on the ligamentum flavum to impede entering the epidural space in all patients. So a lot of times we might have seen that when some of our colleague who is a junior person or a resident who is performing as epidural, he would say that he didn't feel any give way of the classical ligamentum flavum give way what we get in the normal patient. So this could be possible because of the ligamentum flavum midline gaps. So with the help of ultrasound, it helps us to reduce the number of attempts to insert a spinal or epidural. It helps to reduce the number of passes. So what is the difference between the number of attempts and passes? So if you introduce your needle and you change the direction of the needle without removing it, it is the number of passes. But if you introduce your needle and you are not able to get a spinal, you remove the needle and reinsert it, it determines the number of attempts. It definitely helps to reduce the incidence of vascular injury. The pain score in the patients is less, and definitely the complications are less. What about the procedure time? So initially, since has a higher learning curve, definitely when you start using ultrasound for spinal or epidural, the procedure time could be high. But as you progress more definitely you will be able to identify the spinal and epidural space earlier and your procedure time will reduce. However, in spite of this advantage, why it is not utilized regularly? This is basically initially because of the efficacy of the traditional landmark guided technique. So most of our seniors will definitely say that we have been using spinal and epidural since last 25, 30 years, and we have been doing it through the traditional technique, and our chances of failure are less. So definitely this is the third national audit project which was done in 2009. They also mentioned that the incidence of permanent injury due to central neuraxial blockade was almost 4.2 per 100,000 cases. And also the incidence of paraplegia or death was around zero point 0.7 per 100,000 patients. So definitely, as the incidence of any complications are less with the traditional technique, it is not being utilized more frequently. It has a higher learning curve. So definitely to learn and use it on a daily basis, you need to have a regular practice for that procedure. It is relatively difficult to identify the soft tissue window around the bony framework of the spine. So normally when you are performing any peripheral nerve block, like a supraclavicular or an interscalene, you are definitely able to see the muscles, the nerves, and the vascular structures. But while performing spinal ultrasound, we have to negotiate our ultrasound beam in between the two bony landmarks, like the spinous process or the lamina. So it is relatively difficult to identify that window. And definitely in India, it is because of the PCP NDT Act, and which is a hindrance to the availability of the ultrasound. So let us start with the history of ultrasound for spine. So long back in 1971, the first report of ultrasound-guided lumbar puncture was published in Russian literature. In 1980, Koch et al. Used ultrasound to delineate neuraxial anatomy. Between 2001 and 2004, Thomas Grau and colleagues conducted series of investigations that demonstrated utility of ultrasound in epidural analgesia. And from 2010 and onwards, Dr. Manoj Karmarkar and colleagues have done a tremendous, amazing job. So before we proceed to the ultrasound, we need to know the anatomy of the spine. So this is the picture showing the posterior view, lateral view, and the anterior view of the spinal cord at the lumbar level. So what are the components of the vertebral body? So this is a classical example of a L4 vertebral body. So this is the vertebral arch. Posteriorly, we have the spinous process, the lamina, which joins the transverse process to the spinous process, and the pedicle, which joins the vertebral body to the lamina. And this is the central, there is a spinal canal, and these are the superior and the inferior articular process. This articular process unite and join to form the facet joint. So what is the technique for ultrasound guided central neuraxial block? It is mainly divided into ultrasound assisted and ultrasound guided. So ultrasound assisted means you are doing the pre-procedural scanning and marking, and then you're marking a point through which you need to insert your spinal or epidural needle, and then you proceed ahead with the regular spinal or epidural procedure, how you do. And ultrasound guided is in the real time. So in my talk, I'll be mainly discussing about the ultrasound assisted or the pre-procedural scanning and marking technique. So requirements, definitely we need to maintain strict aseptic precautions since we are dealing with the central neuraxial block. There should be no compromise. A low frequency or a curvilinear probe should be used because we are supposed to identify the structures which are more deeper, and thereby the low frequency probe is the preferred transducer. We need to use a sterile marker pen, the sterile probe cover, and a coupling medium. It could be either a sterile jelly, normal saline, or a betadine. So the ergonomics, for performing any procedure, ergonomics have a definite role. It can be performed in a sitting position or in a lateral decubitus position, whichever way you are comfortable. But whenever you are performing it, the person performing, the patient, and the ultrasound machine should be in the straight line of vision. Coming to the anatomy, as I mentioned initially, that for spine ultrasound, you have to negotiate through the bony windows. And this is definitely a point which is important to identify the characteristic patterns, which helps us to identify at what level of spine we are there. So these are the various scanning planes, like the median plane, the sagittal plane, the transverse plane, and the coronal plane. This is an excellent article from 2021 by Professor Hari Kalagra and colleagues. They mention the two transverse views, the transverse spinous process and the transverse interspinous views, and the three parasagittal views, which are at the level of lamina, articular process, and the transverse process. So this is what I'll be describing. So when you're at the transverse spinous process view, the ultrasound beam is hitting the spinous process. In the transverse interspinous view, you are between the two spinous process. In the parasagittal oblique interlaminar view, you are at the level of lamina. More laterally, you are at the level of the articular process, which is the parasagittal articular process view, and lateral most is a parasagittal transverse process view. So coming to the description of each views, so starting from the transverse spinous process view, when you are putting your probe in the transverse orientation and it is at the level of spinous process, since it's a bony structure, it will cast a black shadow beneath and you won't be able to identify any structure anteriorly. As you move your transducer more cranially or caudally, you will be between the two spinous process. And since you're between the two spinous process, there is a definite window through which the ultrasound beam is passing, and you will be able to identify the posterior complex and the anterior complex. This appearance has been described as a batwing appearance. And what, as I mentioned, what is the posterior complex and the anterior complex? So a posterior complex, it is composed of ligamentum flavum, the posterior epidural space, and the posterior dura. Anterior complex is made of anterior dura, posterior longitudinal ligament, and the posterior aspect of the vertebral body. So these structures are usually seen as a hyperechoic line, and it has also been called as a equal to sign. In few patients who are very thin, you might be able to identify ligamentum flavum and the posterior dura separately, but not feasible in all the patients. So even if you are able to identify a single hyperechoic line, that is acceptable. So now this is a video in which I'm scanning in the transverse view. So as I move my probe from up and down, you can see on the left side of the screen, I'm taking my ultrasound probe up and down. And on the ultrasound picture, you are able to identify the back wing appearance. And this is the transverse spinous process view. So this is a bat wing appearance at the transverse interspinous process. And this is the posterior complex and the anterior complex. And this is the spinal canal in the center. Coming to the parasagittal views, in which the ultrasound transducer will be in the longitudinal position. So coming to the first view, which is the parasagittal oblique interlaminar view, in which the ultrasound probe will be just lateral to the midline, and you need to tilt your probe medially. So that's why it's called as a parasagittal oblique interlaminar view. And what you will be able to identify is these are the laminae of the vertebrae. And as you can see, this is the anterior complex and the posterior complex. So this characteristic appearance has been described as a horse head appearance. So this is the scanning for the parasagittal oblique interlaminar view. As you can see, I am just lateral to the midline and I'm moving up and down. So I'm a little bit more lateral. And as I tilt my probe, angulate the probe medially, this is at the level of laminae, and you can see the anterior and the posterior complex. Now coming to the parasagittal articular process view. So as you move your transducer more laterally, you will come at the level of the articular process. And since this, as I mentioned, the superior and the inferior articular process unite with each other to form a facet joint, and it will be seen on the ultrasound screen as a camel hump appearance. So this is the continuous wavy structure which you are able to identify on the ultrasound picture, and it has been described as a camel hump appearance. As I move more laterally, I'll be at the transverse process level. So this is the parasagittal transverse process view. These are the three finger-like projections which you can see. These are the transverse process, and the muscle in between is the psoas muscle, and the muscle above is the erectus spinae. So this characteristic appearance has been described as a trident sign. So this is the video about the parasagittal view. In this, I'm moving from lateral to medial. So as I'm at the lateral level, this is at the level of the transverse process. As I've moved more medially, I've come at the level of the articular process, and you are able to identify the camel hump appearance. And as I just angulated the probe, this is at the level of the laminae, in which you are able to identify the anterior complex and the posterior complex. So this is the horse head appearance. So now, how to systematically scan the spine and guide your spinal epidural. So patient could be in the sitting or lateral position. You need to use a curvilinear probe, and as a rule, you can keep your orientation marker either cranial or caudal, but preferably cranial. So now I have I'm just doing the pre-procedural scanning and marking in this patient. The patient is in the sitting position. The probe is just lateral to the midline and it is at the level of sacrum. So as all of us know, the sacrum, it will be appearing as a white hyperechoic line. And this is the first gap, which is the gap between the L5 laminae and the sacrum. So this is called as the L5S1 gap. And this helps us to identify and start marking your levels from below upwards. Also, another thing is the sacrum is more superficial to the skin compared to the lamina of the L5 vertebrae. Now, as I start moving more cranially, I'll be coming at the laminae of L4, L3, L4, and L5. So this is the characteristic horsehead appearance which I mentioned, and so on. You can start scanning and marking on the patient. So how to do the marking? Suppose if I want to mark at the level of L5S1, I'll keep that, or L4, L5. So in this picture, this is the L4 lamina and this is the L5 lamina. I'll keep it in the center of the screen, the posterior complex and the anterior complex. And then I'll tell my assistant to just make a horizontal mark from the central of the probe. Why? Because the center of the ultrasound picture corresponds to the center of the ultrasound probe, and thereby this will definitely help us to mark the interspace between L4 and L5. Similarly, I'll just move my transducer more cranially and we can start going marking from L4, L5, L3, L4, L2, L3, and so on. So in whichever space you want to mark, you have to keep this picture, the horsehead appearance, in such a way that the gap between the two laminae is in the center of the screen. Now, after reaching a desired level, say suppose L2, L3 or L4, L3, L4 interspace, you have already marked this level. Now you just turn your transducer in the transverse position. So after turning the transducer in the transverse position, you try to get the batwing appearance. So this is the transverse interspinous view in which you are able to identify the anterior and the posterior complex. Again, keep this center line in the center of the screen and you tell your assistant to make a perpendicular line or a vertical line from the center of the probe. Now, after removing of the ultrasound probe, the point of intersection of the vertical and the horizontal line corresponds to the point of needle insertion. So in this picture, I am showing that normally this is the pre-procedural scanning and marking. So when you start sterilizing the bag either with a betadine or a chlorhexidine, these markings may go off. So just to keep that marking in place, I'm just making small impressions with the hub or with the needle cap. So that can stay when you are cleaning and sterilizing the bag. Also, while performing this scan in the transverse orientation, you can identify the depth of the posterior complex. As you can see in this picture, it is around 5.02 centimeter, which helps us to identify at what depth you will be able to get your spinal or epidural. Another thing which I wanted to mention is about the angulation of the probe. So suppose you're getting a nice transverse interspinous view in a horizontal probe position, you don't need to angulate your needle. But if you are getting this picture in a cranial or a caudal direction, then your needle also has to be directed in that orientation. So definitely it helps us to guide the direction for needle insertion. And as I said, this is how I'm marking the screen, marking on the patient's back. So the point of intersection of these two is the point through which you need to insert your needle. So this is our own study which was done long back in 2019 about the anatomical landmark guided midline versus pre-procedure ultrasound guided midline technique of spinal anesthesia in elderly patients. And what we saw was that the number of attempts and the patient satisfaction was better in the ultrasound guided group. Similarly, this is a study from 2021 about conventional landmark palpation versus pre-procedural scanning in obstetric patients. So what they mentioned is that the pre-procedural ultrasound increased the first pass success rate by, and they also said that the increased benefit of pre-procedural ultrasound for those in whom the neuraxial procedure was predicted to be difficult, the complications including the postpartum back pain and the headache were decreased, And the adoption of pre-procedural ultrasound for neuraxial procedures in obstetrics is recommended. And in the opinion of the authors, it should be considered as a standard of care in view of its potential to increase the efficacy. So similarly, multiple studies have come demonstrating the benefit of the ultrasound guided spinal or epidural. So now, as I mentioned, we'll be mainly focusing on the lumbar spine and the pre-procedural technique. But just to cover up a little bit about the idea about the thoracic spine, since at the level of thoracic spine, when you're performing a epidural, most of the times or a spinal, it is more difficult compared to the lumbar level. And this is mainly because of the anatomy of the spinous or the anatomy of the thoracic vertebrae. So as you can see at the mainly the mid thoracic spine from T5 to T8, the spinous process, they are more angulated downwards. The interlaminar gap is very less. The interspinous gap is very less. Thereby, we need to negotiate our needle through the interlaminar space. So this is an excellent article about the real-time ultrasound-guided mid-thoracic epidural access using a novel paramedian cross view. So the authors have described about the 6 views for the thoracic spine. I'll be just elaborating them. The first view is the paramedian sagittal costal view. So as you can see, the ultrasound probe is more lateral at the level of ribs. And you can see these are the ribs and this is the pleura beneath. Second view is the paramedian sagittal, Second view is the paramedian sagittal costotransverse joint view. So as you move your transducer more medially, you'll come at a junction, which is a costotransverse joint, and this will be seen as a classical step sign which they have described. The third view is the paramedian sagittal transverse process view. So as you move more medially, you will be coming at the level of the transverse processes. So these appear similarly like the at the level of lumbar, we saw the trident sign. So these appear similarly at the level of the thoracic transverse process. The fourth view is the paramedian sagittal laminar view. As I mentioned, the laminae of the above vertebrae overlaps the laminae of the beneath vertebrae. They are very much close to each other. And the last view is the paramedian cross view. So what they have done is, after coming at the laminae, they have just tilted their probe in such a way that the cephalad end of the probe is at the level of the spinous process, which is the T4 in this case. The T5, which is in the center of the screen, is at the level of lamina, and the caudal end of the probe is at the level of the transverse process. So what they have mentioned is, in this view, if you insert your needle from the right side of the screen and you target at this level, the needle will uh, enter through the space between the two lamina. So this is a picture what they have mentioned in the paramedian cross view about the needle entry. Coming to scanning of the spine for scoliosis, a lot of patients nowadays we might encounter, they might have some type of scoliosis, and to negotiate the spinal or epidural is definitely difficult in such group of patients. So this is a picture from the article from 2014. And as you can see, the patient has a very gross thoracic and a lumbar scoliosis. So normally what happens in scoliosis, along with the bending of the spine, there is rotation of the vertebrae. So we need to take in our consideration the rotation component also. So if you palpate the patient's back, you might feel the spinous process and you might feel that this is the apparent midline. But because of the rotation of the vertebrae, this is the apparent midline for which we need to insert a needle. So again, for ultrasound scan for patients with scoliosis, there are two approaches, the paramedian approach and the midline approach. So how to identify the midline in such patients? So again, you put your ultrasound probe in the transverse scan, you'll be able to identify the transverse spinous process view. However, the transverse processes and the laminae of the same vertebrae won't be at the same level. So what you need to do, you have to angulate your probe either on the left side or the right side in such a way that the laminae of both the vertebrae come in a straight line. By that way, you can identify the midline and the angulation through which you need to insert your needle. So by scanning from cranial to caudal or caudal to cranial, you can identify the midline in such group of patients, and then you can put the probe in the parasagittal view and look for the horse head appearance, and then you can mark and insert your needle. Just to end the central neuraxial with the caudal epidural, specifically in the pediatric group of patients, they are being used more regularly. So as you can see, the ultrasound probe is at the level of the sacral hiatus, and these are the two sacral cornu, and this is the sacrococcygeal ligament which has been described. So in this way, if you put your needle from center, you will be definitely uh, entering in the caudal epidural space. So this is again the transverse view. Now this is a longitudinal view in which you can see the needle is coming from the right side of the screen, and this is the sacrococcygeal ligament which is being pierced, and the needle is in the epidural space. So now a little bit about the artificial intelligence. We are using it day in, day out for multiple other purposes. Definitely, it has also been developed for ultrasound for the spine. So there have been studies in which they have seen that the machine learning approach to needle insertion site for spinal anesthesia in obese patients. So this was the article in 2021, and this was a complex ultrasound machine with so many connections which they initially started. But they were able to use the artificial intelligence and are able to identify a particular level. They were able to mark those levels, and they were successful. So they mentioned about the initial utilization of the AI for spinal ultrasound. But nowadays we have got multiple other applications and multiple other handheld probes which are definitely automated by the AI, and they, as you can see in this image, the ultrasound probe, as it moves from longitudinal to the transverse, as you start moving, it will help us to identify the midline by marking your center of the patient's spine, and it will definitely help us to identify the level also. Similarly, this is a video from another ultrasound machine, which is a portable machine. As you can see, it definitely guides that this is the midline, this is the spinous process, this is the interlaminar space, and so on. Also, it measures about, helps us to identify the depth at which we can get our spinal or epidural. So to conclude, I would like to mention that the spinal ultrasound is definitely difficult. The structures are deeper, so we need to use a curvilinear transducer. A repeated scanning should be done initially in the normal patients. We need to identify the characteristic sonoanatomical patterns. The patient position, this point I would like to emphasize is that suppose you are doing a pre-procedure scanning and marking in a particular position, then your patient's position should not change. Because if you change the patient's position, the whole marking has no value. So you prepare your patients in such a way that he is in an appropriate position for performing spinal or epidural. Then you do the marking, sterilize the back, and you put your needle. Again, the actual depth is more than the measured depth. So as I mentioned in my talk, that we can identify the depth at which we are able to identify the posterior complex on the ultrasound screen, and then we can put our needle, and our spinal or epidural will come at that depth. But in certain group of patients, like morbidly obese patients who has a lot of skin subcutaneous tissue and fat at the back, so sometimes we might have to compress a lot. So that estimates like 1 to 1.5 centimeter of fat which could be there. So that we need to keep in mind, and we have to calculate it accordingly. Again, the angulation of probe is of very much importance, and we need to keep an eye for the possibility of ligamentum, of gaps in the ligamentum flavum. So patient safety should be our priority. Thank you so much.
On behalf of ICA, I really thank Viral for excellent and explanatory talk on role of USG for difficult spinal cases. But we have few questions which I would like to ask you on the basis of the clinical practice and the clinical scenarios. So I just
Sure,
want
madam.
to know, as you mentioned about identification of a specific level of a spinal epidural,
Yes, madam.
and the relevance of toughest line, which could be inappropriate in certain group of patients. Can you highlight how often have you faced such cases, and what message do you want to give it to all the delegates who are attending this session?
Sure, madam. So, as I mentioned in my talk, definitely multiple studies have been done which has shown that the Tuffier's line not always corresponds to the L4, L5 or L3, L4 interspace.
No, I'm not asking
Yeah.
regarding the
Yeah.
literature and
Yes.
review. I
Yes,
want to
ma'am.
know your clinical
Yes, ma'am.
experience.
So I would like to show one or two cases which we have done. So this, I'll just project my slides. So this was a elderly female, 66-year-old, 108 kilo patient who had a BMI of 43.3 for, and she was posted for total knee replacement surgery. So in that patient, what we did was we scanned the patient initially, we did the markings. Then after sterilizing the patient back, I did the traditional way of marking the Taffier's line. So the ultrasound markings are already done before, and this was how we mark with the traditional way. And what we found out was this is the red line is corresponds to the point by which I was able to locate the L3 L4 space by traditional method. But with the help of ultrasound, my space was a little bit lower. So had I put my needle more at a higher level, it could not be a L3 L4 interspace. So definitely such encounters are very much frequent in our day-to-day practice, and this is mainly in certain group of patients like elderly patients, morbid obese patients, pregnant patients. So in those group of patients, we need to be more careful.
So you mean to say that difficult spinal or attempt of the multiple spinal insertions, you have saved it by doing the ultrasound
Yes, ma'am.
clinical scenario in the beginning, correct?
Yes, ma'am.
Okay,
I have
now,
saved that, and also, madam, I have avoided to put my needle at a higher level compared to what I
oh yeah,
intended
yeah,
to.
yeah, yeah, yeah. Okay, second, I want to know which are the such group of patients in whom such error is most common. So, as you have already said it, that obese patients or pregnant patient or elderly patients. So,
Yes,
these
ma'am.
group of the patients are more getting benefit with the USG guidance, correct?
Yes, yes, madam,
Okay, fine.
definitely.
In elderly patient, why such scenario happens? Any significant change in the anatomy of the spine, do you think?
So, madam, as all of us know, the elderly patients have a lot of disc degeneration. So, in such group of patients, the spinal column or the spinal length also alters. So, because of the disc degeneration and the changes in the spine, the normal level of the spine also comes little bit down. So, if we mark by the traditional levels, the corresponding level could not be a L3, L4 or a L4, L5. It could be L1, L2 or L2, L3. So that is the reason.
In our clinical practice, we found that most of the time the ligaments are calcified, so the
Yes, ma'am.
needles are not going in the midline. So we can decide regarding the change of the
Yes, madam.
position also for inserting the needle, or we can just take another plane to insert the needle. So that is
Right.
also one of the good advantage. Okay,
Definitely, madam.
okay, thank you. Now Shilpa wants to know something from you.
Yes.
Sure, ma'am.
So, Dr. Viral, very nice presentation, very lucid and nicely explained. So,
Thank you.
actually, yeah, thank you, sir. And we try to use this, so as I said in the flyer also. So, we try to use in our practice only when needed. So, what happens? How easy it is to identify the bat-wing appearance or the horse head appearance in clinical scenarios, day-to-day practice? I wanted to know. Also, if I'm not able to see these structures clearly, are there any tricks or tips which you want to tell us, the approximate idea of the interspace and the success of the spinal or epidural? Because we rely कि okay obese patient है चलो सब लोग 5 anesthetists जम जाते हैं sonography
Yes,
machine लेते हैं and then we start searching and then if it fails what?
definitely, madam. So as I mentioned, that ultrasound has a higher learning curve. Again, I'll go ahead with another case. So this was a young male, 149 kilo patient. Height was good, but BMI was 45.9. So in this patient, he was posted for a ischiorectal abscess debridement. So he was not able to sit because of the pain beneath. So we positioned the patient in the lateral decubitus position. So about the uh, how easy it is we are able to identify the space. So what want to emphasize is that in normal workshops or in a young thin build patients, what we do our regular scanning, it might not be the case. So as I am showing this picture in this patient. This is the transverse spinous process view. So the pictures which I showed before, they were much more clearer, but that could not be a possibility in such group of patients who are really morbidly obese, who might have certain edema at the back, specifically in pregnant patients, or patients who might not be able to position adequately. So in these patients, as you can see in this picture, ma'am, this is the parasagittal view at the level of laminae. So as I mentioned, we need to have a certain characteristic patterns in our mind. If I had no idea about that characteristic pattern, I would not be able to identify this anterior complex and the posterior complex. So definitely in morbidly obese patients and such group of patients, the identification of those characteristic patterns are difficult. So you need to first start doing the scanning in a normal patient, then you gradually go. So as I'm playing this video, you can see I'm just moving medial, lateral, and cranial to caudal. So this is at the level of laminae. As I'm moving more laterally, I will come at the level of articular process. So this is at the level of articular process. So as the pictures which I showed in my slides previously, they were in a thin volunteer. Compared to that, the imaging is definitely not that great in such group of patients. Again, this is the same patient in which the transverse view, this is the transverse spinous process view, and this is the transverse interspinous. So it is not very much clearer picture compared to the initial pictures. Another thing, if you are not able to identify, suppose parasagittal lamina at the oblique view at the level of lamina, what I would suggest is to do the marking of the uh, center of the spinal cord. Like you just do put your probe in the transverse view, you identify the midline. So you put your probe at the transverse spinous process view and suppose at the level of L2, L3, L4. So in that way, you are able to identify that whether or not the patient has scoliosis, first thing. And if you're not able to identify the uh, parasagittal oblique view at the level of laminae, you at least know the midline and then you can negotiate your needle in between those two spaces. That's what I would like to recommend. If it is difficult really and you're not able to get a good window.
So, and what about
Right.
the midline is okay, but the
Yes.
interspinous space?
So for that only, madam, if I'm not able to identify the interspinous space, that is because I'm not getting a good window
Window.
through the parasagittal views. So if you have your midline, suppose you have marked your midline, then you can just go between those two spinous process by how we go through the
Hmm.
traditional approach. And you can just put your needle 0.5 centimeter lateral, like how we do for the paraspinous approach. This
Okay,
is
okay.
only
So
if you're not
combination
able to get,
technique.
yeah, this is only if you're not able to get a good window. Otherwise, definitely we need to have the both the windows and we do the marking and
Is
go
it
ahead.
that in lateral position the anatomical landmarks on USG are they seen better? The fat falls off or something? No,
Not much. Means
not
in this
really.
patient, it also luckily we were able to get a spinal, but it was usually it's not much of a difference.
Mm. And in pregnant patient, there was one article where if you give them a squatting position or something, then the USG spines are seen better. Is it like that?
I have read that article, ma'am, but practically we have not done that. So
Acha,
I
not
don't have
done
a,
that.
yeah,
Okay.
yes,
Okay. Thank you so much. Over to you, Manjula, madam.
Okay.
sure.
Thank
Dr.
you.
Manjula, Dr. Manjula,
Yeah.
I just had a small question to Aviral.
Yes,
Yeah,
Very
ma'am.
yeah.
good
Please
presentation.
proceed.
Yeah,
Sure, ma'am.
Aviral, very good presentation. I want to know about the learning curve, like Dr. Shilpa asked. Like for, video laryngoscopy, that a person who is proficient in normal,
Yes,
intubations
ma'am.
or who has the experience
Yes,
of difficult also, like that many numbers, say
yes,
about
ma'am.
10, 12, or a particular number of cases, and then you can, do the video laryngoscopy. So any studies done, to tell us about the learning curve of, doing central Neuraxial block under
So, madam,
ultrasound guidance.
as such, I have not come up to specific studies describing the learning curve, but I would like to mention about my learning curve or what we have seen in our institute. So, normally, I started doing the ultrasound spine long back in 2016 when I was doing my fellowships. So initially when I started for first 2 months, definitely it was difficult. And obviously since I was also learning and I had a expert help to help me. So there are certain minor tips and tricks. If you have someone who is regularly doing it, he'll definitely help you. And initially you first don't jump directly to 100 kilo patient or a 120. First you start doing the procedures or scanning in a normal thin built volunteers. Even if you don't want to waste your time on a patient, you can do the scanning on the volunteers. And say suppose after 10-15 scans you are able to identify the characteristic patterns, you are able to identify the markings, then you go on the normal patients, and then you see how correct you are in the marking a particular space. So if you tend to negotiate that learning curve, then gradually you go to madam little bit morbid patients, and then you definitely go to a morbidly obese patient. So that's what I would like to say. Irrespective of that, madam, after practicing this for so many years, we sometimes do face difficulties at our level also, because each patient is different. In certain group of patients, we still may not be able to identify. But yes, with experience, the time perform the procedure decreases and the success rate increases, ma'am.
I think you have to learn the traditional techniques first, then that is going to correlate better with the USG guided landmarking and finding out the difficulties. Now, my next question goes to Viral again. I want to
Yes, ma'am.
know if difficult cases are posted for the elective surgeries,
Yes,
right?
true.
So how you are going to prepare yourself and your team, what you want to expect from your team to do for you for the better results, and how it is going to be done in those difficult situations.
So, madam, suppose if your patient is posted for an elective procedure and he is admitted, then you can go to the room and do the pre-procedural scanning. So, I would like to again show a case in which we did that. So, this was a 38-year-old female, primary severe PIH with a BMI of 49. She was posted for elective LSCS. So,
Hmm.
what we did was we went to the patient's room one day prior in the evening with the ultrasound machine, and we just saw the spine scanning. So we were much more prepared when the patient was being wheeled in for the spine for the elective section. So I would just like to play this video. So in such group of patients, again, as I said, the picture quality is not as good as the initial images, but yes, I was able to identify the horse head appearance, the anterior complex and the posterior complex in this patient. And
So you mean to say that during pre-anesthesia checkup, you can do the
yes,
scanning and find out what
right.
are the
Yes,
difficulties
ma'am.
you are going to face it, and then you
Yes,
can
madam.
prepare yourself for the better results, correct?
Ma'am, yes, ma'am. We have done this in our setup for another patient also who just came for a PAC for a procedure next week, maybe after a day, 7 to 10 days. So we got the machine in the PAC clinic, and then we just scanned. So just to get a reassurance that whether you will be able to use the ultrasound, whether it would be feasible. So as a preparation for scanning, again, as I mentioned, this is just the pre-procedural scanning. So, uh, if you are satisfied with the views what you have got in the scanning, you can definitely replicate it while you want to perform the procedure. And suppose if the windows are definitely not clear, you need to be prepared with the general anesthesia and the difficult airway cut and everything ready. What
Do
we do
you
for a
have the
normal case.
dedicated machine for yourself to do such kind of the
Yes, ma'am.
procedures?
We have our ultrasound machine in our theater itself, so that we use for all the
No, for the
patients.
pre-anesthesia room.
So, ma'am, for pre-anesthesia room, we don't have. So, what do we do is we call such patients to the theater, and in the pre-op room, we can do the scan. So that's what we do.
So you have
Because,
enough time to do this
yeah,
kind of the
yeah. So
studies
if the
and
patient
proceed
is
further.
electively posted, then we can definitely call the patient in the evening after our case is done, and we can scan and just he can go back to the room. That's what we have done for 1 or 2 cases.
Okay, thank you. Now, I just want to know, as you already mentioned about the way we should scan spine for patients with scoliosis, but it is really possible always to get the views in such patients because of the additional rotation component of the spine which happened. How can we negotiate it?
So, ma'am, as I mentioned in my talk, so this I would like to show about a case which I had done long back. She
Oh,
was
this is
around
really
90
a
years. Yeah. So
very
this was,
difficult.
Yes, ma'am. This was a almost 89 to 90-year-old female. She was a severe kyphoscoliotic patient and she was posted for a Austin Moore prosthesis. She had got a femur fracture and they didn't want to do anything major, but since she needed pain-free and little bit of mobility, so Austin Moore prosthesis was planned. The surgical time, the surgeon said that we would definitely do as fast as possible. But to also along with the kyphotic and the scoliotic component, her chest was bad, and all those things were already there, her saturation. So we wanted to do this case definitely in the spinal thing. So as I mentioned about the difficulty to identify the space in this patient, I was not able to get the transverse interspinous view. So what we did is, this was the right side, the upper picture is the parasagittal oblique view. And in this picture, we were able to identify the anterior complex and the posterior complex. So we started scanning from beneath to above, and then we just identified the anterior and the posterior complex at that level, and we did the marking. So this was the marking which was done in the parasagittal view, not in the transverse view. So in such group of patients, we were definitely not able to identify the transverse interspinous space, but in the parasagittal view, as we can see the window between the two laminae, we marked it and then we inserted our needle and we were able to negotiate. So I would like to mention that in such group of patients, if you're not able to get a specific window, we have two windows, the transverse spinous process window and the parasagittal oblique lamina view. So that helped us in this patient, ma'am.
So you can change the approach and
Yes,
then you can just find out the another window and go proceed accordingly.
yes,
Correct?
ma'am.
This is
Yes,
what you
ma'am.
want to say.
Yes, ma'am.
Okay, fine. Now I think last question from Shilpa's side.
Yeah, so Dr. Viral, it was very interesting to know that when the patient comes for PAC, so like we have our OPD timings 11:30 to 1. So maybe after 1, I'll tell him or her to come to the OT, and then I can scan that patient, right? So it
Yes,
is
ma'am.
something like, in previously in difficult spine, we used to ask for lumbar spine X-ray. So
Yes,
something
ma'am.
like that. Yeah, thank you so much. That is really a new good idea. And see, my question is again practical. What are the difficulties you have faced in your clinical practice? And what are the chances of failure in spite of scanning and marking the spine and then proceeding for central neuraxial block? See, actually, I'm asking this because once, as you said, we had an obese patient. We did the marking. Is there a problem because that is a 2D and patient is
Yes,
3D, and
yes,
still we
ma'am.
weren't able to reach? Then what to do? Thank you so much.
So, ma'am, as you said, since it was a obese patient, so there would be much large amount of subcutaneous fat. So that's what I would like to mention in my previous case. So what this was again a 28-year-old morbidly obese patient, 152 kilos and with a BMI of 52.5. He had no comorbidities and he was posted for ankle fracture. So as you can see, there have been multiple pricks on the patient's back. We tried everything. We had marked the space at 1 or 2 to 3 levels. But what was the problem in this patient specifically was, irrespective of whatever we did, we were not able to get our spinal. So the main problem was the large amount of subcutaneous fat. As you can see, ma'am, in both the pictures, the ultrasound we had to press almost 3 to 4 centimeters deep. And I needed two assistants who were just trying to give me some space to put my probe. So in this patient, what we found difficult was I was able to identify the transverse spinous process view. I was able to identify the anterior complex. But with such huge amount of fat, as you leave the skin, you are your marking will definitely not correspond to the space, because the gap which was there between the while you split up the fat, and as soon as you leave the fat, a needle it continuously used to hit the spinous process. So I definitely we then aborted the spinal epidural. We tried for half an hour, but two or three of us then we were not able to get. We gave the general anesthesia to the patient. But after this, I discussed this with senior colleague members. This is a very nice article from Dr. Bhavani Shankar Kodali. I met Sir himself in a previous conference last month, and he only guided me to this article. So what this is about a novel approaches facilitating neuraxial anesthesia placement in pregnant women with morbid obesity. And he has described how to retract the fat. So this is a specific paniculus retractor which they use for C-section patients. In the morbidly obese patients. So these are the pictures from the SIRS article. What they have done is they have used this retractor to retract the fat at the back. So what he gave me a very nice suggestion that you can use, if you don't have this, you can use your Dynaplast, or you can use a whatever tapes which you have. Then you can retract it. So after marking also the subcutaneous tissue of the skin and the fat, it does not falls back. So this was a very good lesson which I came to know from sir, and definitely will try in our next group of patients. Had I knew this from before and we would have applied in the previous case which I mentioned, in which we had to aborted spinal, it might have helped us to get our spinal successfully. So
But
this is
in
a
these type of the cases, do you think that lateral position is better, because retracting the fat in the lateral position, even with the elastoplast, is easy, and you know that you can get the space feeling, and markings are better in the lateral position, because retraction is proper in lateral position rather than in sitting position.
But ma'am, in such morbid obese patient, no, the table bread giving a lateral position and is also a little bit more trickier. That's what.
I
Uh,
don't know that. I have not done
yeah,
since
even I
long,
have
but
not
I
done.
did a
Yeah,
few cases when the morbid, matlab, too much obesity was there, and then we have retracted with the elastoplast in the lateral position, and we were successful to give a spinal. So that is why I'm just
we can try,
assuming that
ma'am.
it might
Yeah,
be the better position.
we can try, ma'am.
Yeah. Okay.
And
Uh,
ma'am, I would
Doctor,
like to. Yeah, sure, ma'am. You can ask.
sorry, yeah. So once when we had an obese patient, we tried the pyramidal approach. We were reaching, we could see in real time our needle there in the space, but still there was no CSF. So it was that whether our depth was wrong or something.
Dry tap. If the dry tap
So
is there,
Yeah.
you are 100% sure that you are in the spinal space, but you are not getting the CSF. Then can we proceed for the spinal anesthesia, or we should abandon the procedure?
Yeah, in
Because now
USG
you
we
have the
could see the
machine, you are
needle.
sure
Yeah.
that your needle is in the space. So what
yeah,
is your opinion regarding this situation?
ma'am, I would personally not give a spinal, but you can definitely guide us, ma'am.
Okay. No,
Yeah,
because
you were
this
saying
this
something.
situation comes, that
Yeah.
dry tab. We say my needle is in. I got all the things correctly, but CSF is not
Yeah,
coming. So whether I should inject the drug or not, this is the question mark at that last minute. So this is
definitely.
what I just wanted to know.
You
I
were
think one
saying
should not give.
something.
You
One
should
should
not.
not give. Yes.
Okay.
Yeah. So,
Okay.
ma'am, along with this, as madam asked about the difficulties, I would like to mention this very good picture which I have got in a patient. This is about the deficit posterior complex. So, what I want to emphasize is that, as you can see, there is some sort of a gap. It is not a continuous line. So this is thing which I would like to highlight in a certain group of patients. And about the difficulty in the post-spine surgery, nowadays we get a lot of patients with a post-spinal instrumentation. So in such patients, the ultrasound again, it might hinder with the implant. And this is again another study in which the ultrasound guided neuraxial for C-section patients post internal fixation. So these are the pictures in certain group of patients. So what you might not be able to identify the classical spinous process view at a level where the instrumentation has been done. So this is a transverse view in which you are able to identify the hyperechoic shadow of the rods, and this is the parasagittal view in which you are able to see the screws and rods. So what usually we do is we try to negotiate the level at a higher or a lower level compared to the space at which the instrumentation has been done. So this thing which I wanted to include in the document. Uh,
So
Very well,
Once
all
again,
points.
thanks,
Yeah.
Viral, for the excellent discussion also regarding all such kind of the scenarios and situations. Now I will hand over the mic to Dr. Vimla for concluding remark and
Thank you, ma'am.
Thank you, Dr. Aviral, for a very for an very interactive and excellent talk on the subject. And I
Thank you,
think
ma'am.
Dr. Manjula and Dr. Shilpa have uh, I think they have been able to sort out answer most of the queries which the audience must have had in their minds. So wonderful presentation. Thank you very
Thank you.
much. Thank you, Dr.
Thank you.
Manjula and Dr. Shilpa.
okay, thank
Thank
you
you,
very much
madam.
to you all. Now Swastika wants to say something, correct? Hello, madam. Good evening.
Good evening, madam.
अनम्यूट करो पहले अपने आप को. Jayashree madam has just joined, so I just
Yeah,
want to.
she joined. In fact, I think she was there throughout the session.
Okay.
Okay.
Jayashree madam, unmute करो, unmute करो, unmute.
Dr. Jaya, good evening.
Hi, I was
Hello.
going in the other room actually. I was मेरे कमरे में children were there. Please stop. एक मिनट. हाँ जी, good evening everybody.
Good evening,
And
ma'am.
Thank
Good
you
evening.
for joining, madam.
Good
I
evening,
managed to
madam.
Have done
join
the
today,
justice for the
and
topic.
I've been enjoying all these webinars, and truly these discussions just show the experience that is required, and it's only the practice that makes a person perfect. And truly speaking, Dr. Viral has shown that he has worked so hard that now he has this expertise.
Thank
And
you, madam.
I'm very proud of you, Viral. That's really very, very nice. And thank you so much, Manjula and Shilpa, for working so hard for the ICA, and Bimla also taking it forward. This is a very important topic which was covered today, and definitely a tough topic, not easy to uh, practice, and it's only the people who have been doing it day in and day out that of course ultrasound machines also have now become so accurate, and they can help us so much. Can you hear me, Manjula?
Yes,
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 yes.
madam, we
Acha,
can.
okay. So that is really guiding us so well. But anyway, it is our own, and we have to study so much of anatomy. It's amazing that how these everybody has learnt it and taken so much passion into it. And now we were so proud that we are the masters of this, and how our surgeons are actually depending on us to give this block, any block, before they start the surgery. So I'm really very happy today, Manjula. Thank you so much. Uh, you
Thank you,
and
madam.
with Shilpa and the team, Viral.
Madam,
And
we are thankful to you and ICA for giving us
Yes.
opportunity to
no, no,
conduct all
Yes.
these
yes.
webinars.
Yes.
And the ICA, you are taking the
Thank you,
ICA
madam.
forward. That's really great. Thank you very much. Thanks, Bimla.
Thank you.
And
Thank you. Thank you, everybody.
Thank you,
Thanks
Thank you,
again,
everybody.
Dr.
everyone.
Viral.
Thank you so much, madam, for
Thank
giving me the opportunity.
Vineet must have is also there. Thanks,
Yeah.
Vineet
Dr.
and
Vineet.
Swastika. Thank you
Yeah.
so much.
Thank you, ClearNet. Yes.
Swastika, you can just close the meeting.
Thank you.
Thank you.
Okay.
Good night.
Good night. Good night, everybody.
Good night. Good night,
night.
everybody.
So, thanks to all the dignitaries present here. Clarity is really glad to have all these brilliant people together in the session today. Thank you, everyone. Good night.
Thank
Okay,
you.
good night.
Thank you. Good night.